It's a pleasure to be there in order to effectively show you what we already have to perform the diagnosis of the incidental CT finding. Indeed, if you find a central incidental finding, you will go to the standard bronchoscopy, you will go to the EBUS or blind TBNA, there is no doubt. But if you find a nodule not reachable with a conventional bronchoscopy, which is called peripheral nodules, which tool do you choose? I think that you need a strategy. First, you need to look effectively at your CT scan in order to see if you get a C-slice CT scan, in order to see what? In order to see a bronchus sign, in order to see that you can get to the nodules inside the bronch. After that, you need to find the good vehicle that you choose, the good route, the good plan, and finally, did you reach the target? So, to choose your vehicle, obviously, because you need to go far away inside the bronchus, you need to choose smaller bronchus. Could be a 4 mm scope or 3 mm scope with a good working channel in order to pass some tools. It could be interesting to see that you get here 8 mm nodules on the left upper lobe. If you choose a 5 mm scope, you will stop on B3. But if you choose 1 mm less, you will win maybe 1 division, 2 division, and then 3 division, and maybe go far away and find finally the tumor. So 1 mm less could be win a lot of division. The advantage of the slim scope, its maneuverability, the extended range bronchial selectivity, the better tolerate if you perform this under local anesthesia, and also adequate sample because the working channel is good. But the quality of vision could be an issue. It's fragile, and the size of appropriating channel, you can pass small biopsy, but I will show you that's not a problem. The only question is 3 mm or 4 mm. Only one study reports that the ultra-thin bronchoscope, 3 mm, could be maybe more effective in order to perform a good diagnostic yield comparing to the 4 mm with the gaseous. But it needs to be more data to confirm that. In this narrative review, the same author reports that the guidance method, multimodality with the 3 mm, have an overall diagnostic yield about 66%. So after choose your vehicle, 4 or 3 mm, you have to find your route. So you have multiple ways. The virtual bronchoscopy is one. It could be without navigation. That means with a planner, with a laptop, with a pass is performed from you with a laptop, and you have to memorize it, to put the laptop behind you and memorize the way. For example, you see the small nodule here. You will put a mark on the nodule or on the smallest bronchus leading to the decision. You see the bronchus sign, you see the branch here going to the nodule. And he performed from you the way. Right main bronchus, B1, and then you memorize left, up, and down. And you put it inside, or you memorize it, and you go perform your bronchoscopy. It will win for you a lot of time inside the patient and maybe more accurate. It's been demonstrated in multiple articles. After that, you've got another solution, which is called with navigation, with synchronization between the real bronchoscope and the virtual bronchoscope, and the electromagnetic navigation, but this situation are more expensive comparing with the only planner and visualization way. After choosing your route, the question is, did you arrive to the target? You can use fluoroscopy, but there is no visualization for small nodule or glass ground opacities, only in 2 dimensions. It's radiation, it's a little bit cumbersome in the operating room, but it could be helpful to visualize the stability of the tool, the opening of the forceps, and to guide the needle sampling. And to go further, you can also use a cone beam CT. It could lead you to three-dimensional visualization of the relationship between the target and the biopsy tools. It can help to visualize small lesion and glass ground opacities who cannot be visible with a simple fluoroscopy, but it's expensive, it's setting, and it's radiation, and you have to share with other specialties. So finally, you can visualize that you arrive with a radial EBUS. It's a small probe that you insert inside a guide sheath, inside a thin bronchoscope or ultra-thin bronchoscope, and you can push your thin bronchoscope far away, push your radial probes, and see if you're right, it's black or white when you got in the nodule, when you reach the nodules, and let the guide sheath in place and perform the sample, brush, biopsy, needle, etc. You don't need to know about ultrasound. It's white if you are in the lung. It's black if you are if you reach the nodules. You have good results in any publication with low complication, and the factor influencing indeed is the bronchus sign. If you get a bronch leading to the lesion, you will have some very good results. But the position of the probes, depending on the bronchus sign, is very important. If the nodules, if the probe going inside the nodules exactly with the concentric images, there you have got good results. If not, you got less diagnostic yield. The limit is maybe the cost, but it's less expensive comparing to other solutions. But you cannot detect pure glass ground opacity because you cannot define actually the difference between the normal lung to the pure glass ground opacity, for example, here. And you cannot, of course, detect if you don't have a bronchus sign leading to the lesion. So, in my experience, since 12 years now, maybe more, I used always a VB planner plus 4 mm scope plus radial EBUS plus the guide sheath and no scopy. We published this article recently, and we have good results. Global diagnostic yield about 17%. If you get a radial EBUS image, it increased to 70%, and if not, 82. If it's a cancer, sorry, 82%. You see that we select a lot of patients with 87% of bronchus sign, and we perform under local anesthesia in many cases in 82% with only lidocaine. And even if it's small samples, you can have molecular analysis in 77% and PDL1 in 86%. So that's why in a region in Normandy that I live, it became the first line bronchoscopy procedure for peripheral nodule. 84% are referred directly with no previous bronchoscopy. So to conclude, my recipe is a thin CT scan, the bronchus sign, maybe 3 or 4 mm scope, planner, and radial EBUS plus guide sheath. I recommend you the overview performed from, published by Duke Anima and Tess Kramer, which is very great, and overview the advanced bronchoscopic technique of the diagnosis and also the treatment.